Peter. Good morning. Good morning, everyone. Thank you for connecting. So, Peter, first of all, I would like to congratulate for your talk of yesterday, and in particular, more than the talk, for your great job and great experience in this project of DCD donation in Australia for heart retrieval. Just could give you a few words on how did you set up your project and how the entire thing is working.
Thanks, Luciano. In Australia at the moment, 28% of all deceased organ donation is via the DCD pathway. And it's been increasing over the years, and up until recently, we've been retrieving kidneys, livers, and lungs from these donors, but not the heart. And the concern has been that the heart becomes severely damaged in the process of withdrawal of life support. So our approach was to develop a process where we could remove the heart after death in the DCD donor, put it on an ex vivo machine, and we're going to hear obviously about that in this session. We take blood from the donor, we perfuse the heart with the donor blood on the machine, we warm it up to body temperature, and then we can assess, we can then start the heart beating on the machine. We can assess its function, its metabolism, and we can tell from those parameters whether this heart will work if you then transplant it. And so far, in Australia at least, we've transplanted 6 recipients with hearts from these DCD donors, and so far, touch wood, with all patients alive and doing very well, with a follow-up ranging from 4 through to 14 months.
Cool, great. And how would you put in perspective this approach of retrieving heart from non-heart beating donors as compared to just using the same techniques to improve the retrieval of marginal hearts? Because
yes,
we can think of a DCD donor like a marginal heart in certain sense, and while we have a lot of DBD hearts that are not used. So what can be the difference in this approach?
I think cold storage, which is the traditional approach for storing hearts from brain-dead donors, has served us very well and up until recently. But I think one of the things that came out of the session yesterday was the steadily increasing age of donors in Europe in particular. And we know from our own research and research of others that the combination of ischemia with increasing age is very detrimental, especially to the heart. The older heart just doesn't tolerate ischemia at all well. So I think this is where warm machine perfusion has a real role to play in these older donors, because once you put the heart on the machine, you stop the ischemia. You allow the heart to recover and reperfuse in an oxygenated environment. And again, just as I described in the DCD setting, you can assess the function of the heart. The other, with the machines that are currently available, it's also possible to do diagnostic procedures like coronary angiography. So you can actually do an angiogram with the heart on the machine if it's not possible to do it at the donor hospital. So I think it gives you much greater capacity to assess the donor heart, as well as to improve its function and the prospects of a successful transplant if you decide to use that heart.
And how about the relationship with the intensivist? So I've been talking with some colleagues from the Netherlands recently, where they have a lot of DCD donors for lungs and for abdominal organs, and they were saying that they were seeing a sort of a shift in the intensive care unit of patients that could have been potentially DBD donor that have then been switched to a DCD donor. So what do you think about that? So should we still going preferable for the DBD, or is it's going to be exactly the same? So what's your opinion?
I think this has been a concern wherever DCD uptake has been sort of prominent, and this was a question that we were asking in Australia: are potential brain-dead donors being diverted down an earlier DCD pathway? But we've discussed this with our own intensivists, and they are very adamant that that is not the case. And in fact, in Australia, and we're very much in the middle of the pack in terms of our deceased organ donation rate, but our brain death donation rate has been going up at the same time that the DCD donation rate has been going up. So the intensivists tell me that this is a separate pathway. These people would not normally progress to brain death.
Okay.
I think there's probably a grey zone between the two, but there's clearly a group of potential donors who are not going to progress to brain death, but who are potential donors via the DCD pathway. So I think we need to develop capabilities for retrieving, all organs, including the heart, from both types of donors.
And another question that is important, I think, for the relation with the lay public, with the public opinion, and this is something that in my country, in my hospital, the patients, transplant patient organization asked to me when the newspaper were just publishing in Italy, the first heart transplantation from a dead donor.
Yes.
So that was the title in the newspaper. And then I was saying, they were, why have we been transplanted from live donors before? And then you have to explain this. So how is accepted by the public and the public opinion, and this is in Australia? Because heart is not the kidney, so it's...
No, and I think this is very important. The terminology that we use in describing this process is critical, and DCD stands for donation after circulatory death. It's not after cardiac death, and I think the transplant community really has itself to blame for allowing this term to become very widely used within the transplant community, donation after cardiac death. And this creates this perception in the mind of the public, well, how can the heart have died and then you take it out and transplant it into someone else? This is nonsense. And it's not nonsense, it's the use of the wrong term to describe what happens. When you withdraw life support from a DCD donor, you wait for the lungs to stop breathing, you wait for the heart to stop beating, there's no pulse. And then there's an observation time to make sure there's no auto-resuscitation, and then death is declared. Now at that time point, the heart has stopped working, the lungs have stopped working, the liver has stopped working, the kidneys have stopped working. All these organs are retrievable and transplantable if you take them out and transplant them within a very short time frame. But that person has died, but those organs are potentially transplantable, viable and transplantable, if we do it within the right time frame.
Yes, so this is a great... I think it's a great view in for improving the possibility of transplanting and saving more life. But how about the ethical issues? So I mean, of course, all of us as physician is always trying to behave in the most correct way, and we are doing our job to save life and to improve patients' outcome. But one question that has been risen also here in Europe, there have been some misbehaviors in some places where, with the DCD donor, you have, you decide to stop the care, and on one hand you can decide to stop the care anyway, but on the other hand with the transplantation you decide to stop the care, but on the other hand you know that you are improving something else. So how this is ethically being addressed in your country?
Well, I think the critical issue here is complete separation of the people making decisions about withdrawal of life support and the people who are involved in transplantation. And in Australia, decisions about withdrawal of life support are made by intensive care specialists, and those discussions with family and decisions are made completely removed from any talk about organ donation. And we have a policy in Australia that all intensivists, as part of their training, are trained to have these conversations, where it's about withdrawal of life support in circumstances where maintaining ventilation is futile. It's futile and it's burdensome for that individual. So this is allowing palliative care to take place, providing comfort care as appropriate. If the family agree to that, then there is a discussion about potential organ donation. And if the family agree to organ donation, then they still are allowed, they have their withdrawal of life support. where that occurs, whether it's in the intensive care unit, whether it's in the anaesthetic bay or an operating theatre, that really depends on local jurisdictions, local hospital policies. But I think the priority is the care of the individual, the potential donor, and that person's families.
Okay, so thank you, Peter, for taking this time to talking with us and to the public at home, and again, congratulations for your pioneering work. And I think that in 20 years' time, you will be one of the people that changed the history of transplantation. I think, because this technique is really changing how we are going to approach heart transplantation in the future.
My only hope is that we can help more people.
Yeah.
So.
Okay.
Thank you, Luciano. Okay.
Thank you, Peter.